All right. Good evening, everybody. Obviously, tonight we're talking about utilizing deadlifts in the management of low back pain, something that I really enjoy talking about. For those of you that don't know me, my name is Zach Long. I'm one of the faculty members inside of the fitness athlete division, teaching both our live clinical management of the fitness athlete course and our advanced concepts course. The advanced I teach with Mitch, and the live I teach with Mitch and Alan. Um, Please feel free to interrupt me at any time tonight. I typically don't have the chat bar up. So if you type stuff in, I'll try to pause a couple times and go look in the chat bar. But I'd prefer if you have questions, just mic up and interrupt me at any time. Don't worry about the interruption. Um, that just typically works better for me. And so let's dive right in. Obviously, in the rehab world, when people are dealing with an injury, we now are getting a better understanding of the need to properly load people to create the adaptive changes that we want. Can y'all see my PowerPoint right now? I'm seeing a black.
Yeah, it still says it's loading.
All right, we might just have to deal with that small picture. Um, in the rehab world, when something's injured, we now know that we have to load those tissues to get them to remodel appropriately, to strengthen, to be able to tolerate the loadage that led to them being injured. So if somebody comes in with rotator cuff pain, we are strengthening the rotator cuff. If somebody comes in with Achilles tendon pain, we're doing some eccentrics or heavy, slow resistance training to load that up. But when people come into the clinic with back pain, we still haven't grabbed onto the idea that just like every other area in the body, when you come in with pain in an area, we strengthen that area. And I think that's what low back pain and utilizing deadlifts comes down to is 75% of the effects of deadlifts are simply getting that area stronger. The other 25% is this giant psychological effect that people get when they are scared of their back and they go and pick up some weight off of the floor. When they look at a barbell that has 95 pounds on it or 200 pounds on it, whatever it is, and they're a little nervous about it, and they kind of gut check themselves. They walk up to the bar, they get down, get set up, lock their lats in, grip that bar, and pick it up off the ground. There is something awesome that happens when people do that. And so often, you'll see that 35-year-old mom that's been scared of picking her child up out of the crib for the last 2 weeks because of how bad it's hurt her back. She goes and picks up that 95-pound bar and she drops it at the end of the rep and she just smiles at you. And she's got this look of pure joy and pure badass at the same time. And that's what treating people with deadlifts comes down to. It's just creating this psychological impact of people feeling like they are stronger, that they're not super weak, that they're not super fragile. So again, I'm excited to dive into this tonight. So we'll quickly start by basically looking at some of the research in the utilization of deadlifts for low back pain. There are a couple other studies beyond the two that we're going to talk about tonight, or actually four we're going to talk about tonight. And if you've listened to the PT on Ice Daily Show, if you've been to the lumbar spine management course, or any of the fitness athlete courses, you're probably familiar with this research. But this first study is by Assa and colleagues, published in 2015. They took individuals with low back pain and split them up into two groups. One group was a low load group. So they basically sat down with the patients and they said, tell us what's been bothering you. They do an objective examination. They take a patient specific functional scale. And then based on all of that stuff, they came up with individualized exercises to address the issues that that patient had. And they did that with all low load exercises, nothing heavily loaded. And then the second group, they simply said, all right, y'all are going to go deadlift. And then they compared those two groups. And what they found was both groups had significant improvements in their pain intensity, strength, and endurance. And there were no differences in the pain changes between groups. But the low load group did show significantly greater changes in their patient specific functional scale, which 100% makes sense. So they set these people up to where, they wrote down their patient specific functional scale goals, and the therapist and patient worked specifically at improving those things. We're going to talk later about the scientific principles of strength. One of those is specificity. So when you do anything with a specific goal in mind and you train for that goal, you're going to see improvements towards that goal. That's what happened here. But as y'all know, at ICE, we're about and, not or. So when we read this study, we think two things here. Number one, why not do deadlifts and interventions that specifically target that individual's pain and throw in some manual therapy? Like, wouldn't that be the best of all worlds? So that's one way to look at it. The second way to look at it is neither one of these groups had better improvements in their pain than the other group. But if we're looking long term here, and Sally comes in and she's 40 years old, she's never really been active before, and we're looking at what's going to make Sally the most robust human being she could be for the next 30 years of her life. What's going to make her as strong as she could be? What's going to decrease her risk of mortality, etc. And it's going to be deadlifts. Deadlifts are an exercise, or just like any significant strength loading, they are an exercise that can truly change people's long-term health and fitness. And we just don't believe that dead bugs and clamshells and bird dogs have that same long-term effect on somebody's overall health and fitness. So that's why you'll see across the entire ICE curriculum, from Justin Dunaway teaching total spine thrust and persistent pain, to Jeff teaching lumbar spine management, to the fitness athlete crew and modern management of older adult. That's why you see all of us so in love with deadlifts, because they can literally change people's lives. I won't bore y'all with the specific details of these studies, because I really want to get into the meat and potatoes of how we program deadlifts and how we perform deadlifts. But they did do a follow-up study to that first study we just discussed, where basically they took the deadlift only group and they said, what were the factors that made individuals more or less likely to respond to deadlifts in their training? And the number to remember here is 60. So those that had less than 60 millimeters on the pain visual analog scale and could hold the Byring-Sorensen test for greater than 60 seconds were those that were most likely to benefit from from deadlifts in their management of low back pain. So they had moderate or less pain intensity, and then they had a I don't even want to call it a decent, they had a somewhat decent level of lumbar spine endurance. We'll go over this Byring-Sorensen test a little bit later. But that's who they found were most likely to benefit from deadlift training. Now, to me, when I look at this, if somebody doesn't have a 16-second Byring-Sorensen test, if they don't have great lumbar spine endurance, what am I going to do with them? I'm going to do some maximal deadlifts and some other exercises that we'll talk about later. But 60 is the number to remember. That's their protocol. Again, I'm not going to bore you all with that, so we'll skip through that. This isn't just a fitness athlete thing. This is every patient that walks in our door needs to be understanding a little bit better how to perform a proper deadlift. This study is a great example of that. The Liftmore trials put out in 2017, where they took postmenopausal women with low bone mass. They had one group do deadlifts, overhead presses, and back squats 5x5 at 80 to 85% of their 1 rep max. So these women were getting after it here. 5x5 at 80 to 85% is some heavy loading, more than what most of us do in the clinic. The other group did some low intensity loading, where the heaviest weight they lifted was 3 kilograms. It was mostly stretching and body weight stuff. And basically across all of the measurements that they studied in this research study, the people that did the heavy loading were the only ones that saw the positive adaptations from that. So we have to be significantly loading people across their lifespan. Another study here looking at sarcopenia and having individuals do 3 sets of 8 to 12 at 60 to 70% of their 1 rep max, which included a large range of exercises, including deadlifts, and they saw significant improvements in a variety of different things that they measured here. And there are so many other studies in this older adult population that we could reference here, basically just screaming our need to load people better and do more functional movements such as the deadlift, but we won't go through all of those. So that we can spend a little bit more time diving into the technique of the deadlift and what we want to see from proper deadlift form, and what are the things that we don't want to see, and then how do we actually go about programming that with the patients that walk into our clinic, whether that's somebody that actually wants to deadlift, maybe they're a power lifter or a CrossFitter, or somebody that just needs to deadlift as part of their low back pain rehab, or somebody that doesn't even realize that they're deadlifting on a daily basis because they work at Lowe's and you're treating them for a workers' comp case, and that's an individual that has to be able to pick up a 50-pound bag of seed every day, multiple times. How do we go about improving their biomechanics so that they are as efficient as possible in those lifts. That's what we're going to dive into now. So when we talk about the deadlift, we have to remember that the deadlift is a hip hinge dominant movement. What do I mean by that? If we look on the right, we're looking at a stick figure doing a squat. During the squat, we see a significant amount of knee flexion and a significant amount of hip flexion and ankle dorsiflexion. So that basically, if we drew a line up from the middle of the foot, the knee is being pushed significantly anterior to that line, the hip is posterior to that line, and we're creating a moment arm around the knee joint and the hip joint. When we look on the left at a deadlift, we do see some knee flexion and some ankle dorsiflexion most of the time, but that's significantly less than what we see in the deadlift. Instead, we see significantly more hip movement happen. So this creates a larger moment arm around the hip joint, a lot of torque for the hip extensors, and a shorter moment arm for the knee extensors. To make that simple, we see the hip joint move significantly more than the knee joint. In the squat, we see both the hip and the knee move significantly. And that's a big difference because we're going to see a lot of individuals when it comes to performing the deadlift, especially those from maybe a CrossFit population, that get really squatty in their deadlift and don't hip hinge quite as much as we'd optimally like to see. And so the way I typically go about teaching an individual to deadlift when they haven't deadlifted before or they haven't deadlifted for a long time is like this. I like to teach it from a top-down approach. So I'll start on the far right here, where this individual is standing up tall, maybe they're holding a kettlebell, and then they do a hip hinge movement. So they have soft knees, they bend at their knees a little bit, but then they push their hips back as they flex their hips forward. And once they get to that position, where that middle picture is, where their hand is right at knee level, then I allow them to free their knees up. I allow them to bend more at the knees, maybe push the knees a little bit forward, but bend just enough that they can maintain pretty much that same torso angle, but then get down to the ground. That torso angle will be a little bit different like you see there in the picture, but we're maintaining a very similar torso angle. So again, we start tall, we hinge forward until the hands are at about at the knee level. So I'd actually go a little bit deeper than this individual is here in this picture, this middle picture. And then we flex the knees enough that we get the bar down to the ground and the kettlebell down to the ground. So that top-down approach makes it really, really simple to teach the deadlift. Then there are a few other finer points for what we want to see. So we want to see a brace neutral spine throughout the entire movement. And we can kind of put that neutral spine in quotations there. We know from some research that the lumbar spine is going to flex during the performance of a deadlift, but we are striving to maintain a neutral spine. We think that's where people are going to be most mechanically efficient. And also, if they're striving to maintain a neutral spine, even if they flex, we know that conscious attempt to stay neutral means that they're using active stabilization here. Their low back muscles are actively trying to hold them in position versus relying on passive structures, versus just hanging out on their ligaments. So we cue brace neutral spine. In that setup position, if we drew a line up here, if we were looking right from the side of the bar, if we drew a line straight up, we would see the shoulders slightly over the bar. So we'd probably see the bar sitting right at about Mitch's armpit level there. We typically have a stance about hip width, so it's a more narrow stance than what most individuals will have for their squat. The bar starts close to their shins, and the shins are relatively vertical. Some people will be a little bit past vertical, but it's typically going to be more vertical than somebody's squat setup is. Mitch has a little bit more of a forward shin angle there than I do in my setup. Nothing wrong with Mitch's setup there, but most people are at about Mitch's level or closer. That bar again stays close to the shins because I look at the entire deadlift as trying to keep the bar as close to the hip joint as possible. The closer the bar is to the hip joint, the more mechanically efficient we are, and that's what we want in this movement. Now, as Mitch lifts the bar off the ground from here, from that initial pull, from basically the time the bar's sitting on the ground to the time the bar reaches his knees, we want to see his hips and shoulders rise together. And then once he gets past that point, then his hips will open up a little bit and they'll push forward and his torso angle will change a little bit. And then he'll stand all the way upright. And then as he initiates the descent, Mitch would send his hips back and do a hip hinge movement to start to initiate the deadlift. Is everybody with me so far here on the points of performance and why we want to do deadlifts? I'll pause for a minute, and if anybody wants to put anything in the chat bar, they can. All right. What's up, Gmo and Brandon Vaughn? Good to have y'all. So from points of performance, now let's go into the faults. What are the things that we see in the deadlift that we really don't want to see? And we want to work on fixing when we do see. So the first thing is going to be a loss of neutral spine position. This is going to be the thing that we most commonly see, where as that individual starts to do a deadlift or during the performance of the deadlift, they start to really flex their lumbar spine or thoracic spine as they perform the movement, and they end up relying more on those passive tissues versus active tissues. And while we are not scared of unloaded spinal flexion, we do believe that at a certain point, maintaining a more neutral spine position is going to be important to mitigate injury risk and to be most mechanically efficient. So that's why we want to cue for maintaining more of a neutral spine position. And so commonly we'll see this happen when individuals deadlift. So during the execution of that lift with every rep, my low back rounded. That's not the best example of it because I have so little lumbar spine flexion that my lumbar spine flexion looks like most people's neutral. But we want to cue away from that. The second thing that we're going to see a lot of is a poor setup position. So on the right, if we drew this line up that you see here, this white line, up straight vertical from the barbell, we'll see that that line ends up being right over the armpit, or right in line with the spine of the scapula. That's where we want most people's setup position to be. Where we'll see a lot of individuals end up being is what we see here on the left, where they're in much more of a squat pattern. So you see Mitch has a lot of hip flexion and a lot of knee flexion there. And then when we draw that line up from the middle of the barbell straight up, it ends up being over the middle of the shoulder rather than the shoulders being slightly over the bar. This is something that we're going to see in a ton of CrossFit athletes. So CrossFitters performing both the deadlift and the Olympic lifts, very commonly they'll end up setting up in their deadlift as if they're doing an Olympic lift, and they'll end up doing this giant, really big push off of the ground rather than it being a more hip hinge dominant pull off of the ground. And that'll lead to some issues in some individuals. So as you can see in this picture, Mitch's knees on the left are really far over the bar. And so if somebody's in this really squatty setup and they don't do a really good job of driving off of the ground and pushing their knees out of the way of the bar, they'll end up forcing that bar to go forward. And if the bar goes forward off of the ground to move around the knees, that's going to increase the distance that the bar is away from the hip joint. The further the bar is away from the hip joint, the larger the torque we put around the hip. Essentially, the more strain we put on the low back. And if you go into the clinic tomorrow and you grab a 45-pound barbell and you start in these two different positions and just lift off the ground from these two, you'll feel that if you're in a more squatty setup, you'll feel your low back have to tighten up significantly more. You'll feel more strain in that area. Versus the right, you'll feel significantly less strain in that setup position. So this video kind of demonstrates the difference between those two setups, where in this initial video, I'm really squatty in the setup, and you can kind of see the bar move forward as it comes off the ground. Again, that's just increasing the distance it is away from the hips. And then if we don't squat so much, we'll be able to maintain the bar a little bit closer to the hip joint throughout the entire movement. Again, this is probably, for me, in the CrossFit population that I treat so heavily, this is probably the biggest thing that I see, is this poor setup position, because they're so used to the Olympic lifts and the setup in the Olympic lifts that they don't know how to actually perform a true hip hinge style deadlift. And then when they go to deadlift, they end up pushing that bar forward off of the ground and increasing the amount of strain on their low back. And simply cleaning that position up makes drastic changes in their low back pain. So we'll see what we see kind of here on the right. We're off the ground. If we start in a more squatty setup, that bar, you can see this in the far right section, the middle picture, that bar moving forward off of the ground, and that positions it further away from the hip joint. We'll also see from a bar path fault a lot of individuals that don't engage their lats. And the lats are going to really keep that bar tied close to the body and keep it as close to the hip joint as possible. The lats not being really active in the deadlift is probably the second most common fault that I see in the populations that I treat. And so in the far left series of pictures, you can see in the far left, that's me set up without engaging my lats, where you can see that bar is sitting 3 or 4 inches in front of my knees, versus the right, I engage my lats, my shoulders are a little bit extended, the bar is sitting right there on my thigh. That is decreasing the moment arm around my hip. That's decreasing the amount of strain that I'm putting on my low back. And again, if you go in the clinic tomorrow and you grab a barbell or you grab a kettlebell and you hinge forward to the point where that bar is resting at about knee level, and you let that bar drift away from your body, you'll feel your back tighten up. You'll feel it work a lot harder. You'll feel it be strained a lot more. And then you pull that knee back and have it touch your thigh. You'll feel that strain in your low back go down. This is about just being as mechanically efficient as possible. And the lats play a huge role in that in the deadlift. Here's another example of why that is so important. So in the top picture, this is Greg Nuckols. Greg Nuckols runs a wonderful website, strongerbyscience.com, that if you want to know anything about biomechanics as it relates to the strength lifts, Greg Nuckols is a fantastic resource. He's put out a lot of really good free guides, like hundreds of pages worth of free guides reviewing research studies. Highly recommend his stuff. But this is a picture from his website. In the top picture in that deadlift, you can see that Greg's arms are dropped straight vertical. And then the distance that he has from his hip to his shoulder joint there is significantly more than that bottom picture. When he engages his lats and you see his shoulders that now in a little bit of extension, that significantly shortens the moment arm. So you can see how that is shortened by engaging the lats. The lats and the shoulder joint are what connects the bar to the body. When we engage them, basically we end up being 3 to 5% more mechanically efficient. And 3 to 5% makes a big difference when it comes to people dealing with pain. And so we want to see those lats engaged throughout the entire movement. And this video kind of outlines what we see when people don't engage their lats and when they do. So this is no lat engagement. You'll see even from the ground, the bar's kind of drifted away from my body. And at the very top, you'll see the bar kind of drop back towards our hips. Like at the very top, it's 2 or 3 inches away from my hip, and then it slams back into my hips, versus if the lats are engaged, the bar stays close to the body the entire time. Once the bar passes the knees, it simply just slides up the thigh. And so that keeps it as close to the hip joint as possible. And again, it makes us as mechanically efficient as we can possibly be. Another fault we'll occasionally see is an overextension finish. So a lot of times, depending on your federation, a lot of people want to see you like flash your hips open at the top of a deadlift. And what many individuals will do is they'll end up going into lumbar spine extension to finish the rep, rather than finishing by squeezing their glutes, which you'll see. Maybe you won't see that. I don't think I did good reps in this video. But we want to see people in with a neutral spine. We want to see them start and end the deadlift with a neutral spine position. The final fault we'll talk about is people that shoot their hips off the ground too fast. So you'll see in this video, instead of my hips and shoulders rising at the same rate, my hips shoot up significantly faster than my shoulders. And so I'll pause it for you for a second. My hips have shot up. I now have a really flat back position there, and it's just not an efficient position to begin to move the bar off the ground. Now, this will happen for a couple of reasons. Sometimes it happens when people start their deadlift too squatty. So they start with their hips way too low. And so their initial movement is to shoot the hips up to where they're just in a better starting position. Other times you'll see it happen when individuals just don't know how to deadlift. So you have to give them a cue of keeping their torso angle the same off of the ground, which if you use the wordage I just used there, that's not going to be a cue that works very well with your populations. They won't get what you mean. So typically I put one hand on their low back, one hand on their upper back, and I tell them I want them to just press their upper back into my hand more off of the ground. And that tactile cue typically changes that. The third reason that you'll see people do this sometimes is people that are really, really strong in their posterior chain and really weak in their quads. So they really try to move this to a position where they're loading that posterior chain a little bit more. An example of this would be Justin Dunaway, who teaches total spine thrust and persistent pain. Justin's posterior chain is significantly stronger than his quads. I think he deadlifts like 350 or more and squats in the lower twos. So there's an imbalance there between those two numbers, a significant imbalance. And Justin just doesn't have a great quad drive off of the ground. And so that happens. And I guess now that I'm thinking about it, there is a fourth time where this will happen. Sometimes you'll see really, really flexible females do this. So as they're standing at the top of their deadlift, they'll essentially just continue to hinge forward more and more and more and more until they reach the ground. And so they'll never really go through much knee bend. They'll do a straight leg deadlift, essentially. And I like straight leg deadlifts as an accessory exercise, but if we're trying to lift maximal loads from a deadlift perspective with a straight leg, we want to have the knees bent a little bit in the bottom position so that we can actually use our quads to start moving the bar off the ground a little bit. And if we stay completely straight legged, we don't get much of a leg drive off the ground. And again, that's just something we'll see in really, really flexible, typically female clients. And so for those individuals, if I see them really straight legged, then I'll tell them, I want you to tell me how much tension you feel in your hamstrings and how much tension you feel in your quads. And typically they'll say like, yeah, I feel like 8 out of 10 tension in my hamstring and 2 out of 10 in my quads. And I'll say, all right, let's take that down to 6-4 or 7-3. And giving them those numbers of what to feel for from a tension perspective is also a really great way to help improve people's starting position there. I'm not exactly sure why that clicks so well, but it clicks all the time with a lot of individuals to just have them rate and then change the rating of what they feel in those bottom positions of their deadlift. All right, so if somebody comes in and they're having deadlift related pain, or I'm trying to teach them a deadlift with good form for the first time, and I just don't make any progress on improving their performance, what do? Then I start to break out the components of the deadlift. But I typically only do that after I've spent a little bit of time trying to coach their deadlift and improve those positions first. And so we'll talk about a couple tests that we use to break out the deadlift. First is going to be the PVC pipe hip hinge test. So we take a PVC pipe and we have it touching 3 positions: an individual's sacrum, their thoracic spine, and their head. And that's essentially our marker of if neutral spine positioning is maintained. And then I'll ask them to hip hinge forward. So I'll say, with soft knees, I want you to bend forward at your hips and go as far down as you can go while maintaining those 3 points of contact. And what I'm looking for is this right picture here, a picture of me. Y'all might not recognize that as me. That's me before I had a beard. That's baby Zach. So I want to see baby Zach be able to hip hinge far enough forward that they maintain that neutral spine position as represented by maintaining those 3 points of contact. And then if we drop that PVC pipe and then lower the arms down without moving hip positioning, the hands would be at or below knee level. That would, to me, signify that they have the ability to maintain neutral spine positioning as they go through a hip hinge position to the point that we talked about earlier when I talked about my top-down approach, that they can get to this middle picture and then bend their knees to get the bar down to the ground or the kettlebell down to the ground. But I want that hip hinge to the knees first. So we'll see 3 faults with this test. Far left here, we'll see a flexion fault, where as that individual descends down, they flex their low back, They'll flex their low back, and you'll see that bottom point of contact be lost. Sometimes we'll see this middle picture where this is an individual that has an overextension fault. So as they go forward, they lose that middle point of contact because they're extending too much through their lumbar and thoracic spines. Typically, this is going to be somebody that comes to you like from a gymnastics background, a cheerleading background, where that extension position for a long time has been their default position of stability. And then the third fault we'll see is people that have a lack of posterior weight shift. So that's what we see here on the far, far right, where that individual's hip does not translate posteriorly as they hinge forward. Instead, they just flex their trunk forward, versus what we want to see is the left picture there, where the trunk flexes forward, but the hips also translate posteriorly. That is an individual that is loading their low back, their hips, their glutes, and their hamstrings. The person on the far right is loading their hamstrings and low back. So if you just play with this on your own, you'll feel that when you do this straight trunk flexion movement, you'll feel a lot of tension in your low back and a lot of tension in your hamstrings. And very typically for me, when I see this, is in very flexible, typically females who come in with low back pain or high hamstring strains, because they just don't know how to spread that load out between the entire posterior chain, and instead they put more of that strain on their hamstrings. Now, if an individual passes this hip hinge movement, then I don't need to test anything else. Like, I know that they have the prerequisites to do a good deadlift. I just need to go back and coach the deadlift more. If they fail it though, I need to dive deeper into what's going on and why they're having issues. And so to do that, I'll look at the supine active and passive straight leg raise. So active straight leg raise, one leg stays flat on the treatment table. The athlete keeps the other leg straight, knee straight, and lifts it as high in the air as they can. And I want to see an 80-degree hip flexion angle there, and we can look at that actively and passively. And this is kind of the algorithm that I follow that kind of makes it dummy proof for me on knowing where I need to start working on individuals' deadlift or hinge pattern. If they pass the hip hinge test that we discussed, then and their deadlift is poor or they're having deadlift related pain, then I need to start working on their deadlift specific technique, their deadlift strength, their lumbar spine endurance. If they fail it, then I'm going to go and test the active straight leg raise. If they now pass the active straight leg raise, I've basically proven that they have the ability, when we take gravity away, they can move their lumbar spine and hip separate from each other. And so I then need to figure out, how do I improve their hip hinge pattern? Because they have the prerequisites to a hip hinge, but their hip hinge isn't good enough. If they fail the active straight leg raise, we test passive. If they pass the passive straight leg raise, then we need to teach them how to start to disassociate their lumbopelvic motion from their hip motion. We need to work on some core stability, motor control stuff. If they fail that test, then we work on basically posterior chain flexibility. But no matter where somebody is, basically in this perspective, I'm still doing some sort of loaded deadlift variation, or one of the variations or regressions from a deadlift that we'll talk about in a couple minutes. But I almost always have people doing something along the deadlift spectrum. A couple of other tests I'll look at, it's going to be the Byring-Sorensen test, the straight leg raise test, the slump test, and the prone instability test. So the Byring-Sorensen test, when we talked about the first two studies by Assa and Berglund in 2015, the second study, they basically broke out who are the individuals that are most likely to positively respond to deadlifts being part of their low back pain treatment. And the two numbers, or the one number was 60 millimeters on the pain visual analog scale, and the second number was greater than a 60-second Byring-Sorensen test. So when you look at research on the Byring-Sorensen test, you'll see this picture on the far left, where an individual is lying prone on the treatment table. They have their ASIS right on the edge of the treatment table, and then they'll have a couple of straps holding the rest of their lower extremity down to the table. They'll rest their elbows on a box, and then they'll lift their arms up, cross their arms across their chest, and then maintain this positioning for as long as possible. Whether that's they stop because of pain, or they stop because they lose neutral spine positioning, or they stop from fatigue. They measure how long individuals can hold that. And basically, in the studies that have looked at this test, they found that people that have never had back pain can hold this for longer than people that have previously had back pain and significantly longer than people that are currently experiencing back pain. The way we typically do this, at least the way I've traditionally done this, is on a glute ham developer, where I have that individual get their ASIS right on the edge of a GHD with a plyo box in front of them. We then go to that same testing position and we see how long they can hold it for. And again, the number there is 60 seconds on the hold time there. But like I said earlier, if I'm trying to improve somebody's lumbar spine endurance because they can't hold this for 60 seconds, what am I doing? I'm doing submaximal deadlifts to build their lumbar spine endurance, or some of the other exercises that we'll talk about in a few minutes. I think it's also really important for us to talk about nerve tension testing here, because obviously the deadlift, where we're going through a significant amount of hip flexion with the knee extended, it does put tension on the sciatic nerve. So I think testing somebody's slump and straight leg raise testing also gives me some really valuable information here. There are two types of deadlifts that we'll typically see in the clinic. One is this, or we'll see people perform. One's the sumo deadlift, which is less popular here on the left. The conventional deadlift there on the right. The sumo deadlift is a little bit more of like a squatty position where we have more knee flexion relative to the conventional deadlift. We have these really wide legs. And the combo of things that set up the sumo deadlift here basically leads to a little less neural tension. Those legs being abducted decreases neural tension. And that torso being a little bit more upright that we see in the sumo deadlift also decreases shear forces in the spine, which we'll talk about in a second. But for some people that are dealing with significant neural tension, the sumo deadlift may work better. I also use the prone instability test in the clinic a lot to kind of help me guide people to where they should go with the deadlift. Again, typically I do the conventional deadlift, but sometimes with people that have neural tension or a positive prone instability test, I'll kind of have a gut feeling that the sumo deadlift works a little bit better. With the prone instability test, we basically take two fingers, the two thumbs, and we put them in the spinous processes of the lumbar vertebrae with an individual relaxed and laying over the edge of a treatment table. We then push straight posterior to anterior with 2 pounds of pressure, and we look for reproduction of that patient's familiar pain, what they're coming in to see you for. And then if we find a spot that produces their familiar pain, I then have that individual lift their legs up off the floor like you see Jordan doing here on the right. Jordan's my business partner, and he's demoing this with me. If them lifting their legs up and activating their posterior chain decreases their pain when I provide that same PA force, then I know that they have a positive prone instability test, that maybe shear forces might be a little bit more stressful on their back. I don't tell them that their back is unstable. To me, I then say, look, this is great news. Like, if we just get your low back a little stronger, I think your pain's going to go completely away. And that really sets people up to understand why we're going to load them so heavily in the clinic. But again, if somebody's positive on the prone instability test and or has a lot of neural tension on board, sometimes I'll be more likely to go with the sumo deadlift versus the conventional deadlift. And I'll give you all some case studies for that here in a few minutes to kind of outline some specific examples of when I've used each. So if we follow the algorithm that we talked about a few minutes ago when it comes to the hip hinge, the supine active straight leg raise, and the supine passive straight leg raise, it'll basically tell you if somebody's having deadlift issues, where you need to go. So for instance, if somebody's having some posterior chain extensibility issues, so they fail all of the tests all the way down to the passive straight leg raise, what are we going to do? Whatever we can do to get their posterior chain moving more. We're doing some soft tissue mobilization for temporary increases. We're doing static stretches or pails and rails, where we're doing static stretching plus isometric contractions. We're doing eccentric motions. Maybe we're doing something like a Romanian deadlift shown here in the picture, where we do a slow tempo down to try to really elongate the muscles of the posterior chain, or maybe we're doing some neural gliding to try to improve nerve mobility there. If somebody failed the active straight leg raise but passed the passive, I know that they have the posterior chain extensibility, but they don't know how to dissociate their low back moving from their hips or hamstrings. And so that's when I'll use a lot of exercises such as leg lowers, shown here in this little stick figure, where one leg is held, both legs start held up straight in the air, and then one leg's lowered down and raised back up. And we're just working on learning how to brace and maintain a neutral spine position as the hips move, or we're doing this picture here on the right where Mitch and I are doing quadruped rocking. So I have a PVC pipe along my spine, and I'm just sitting my butt forward and back, working on moving from the hip separate from the low back. If somebody failed their hip hinge test, but passed the active and passive straight leg raises, then I know they need to work on just their ability to do a proper hip hinge. So we'll do things like this bottom picture, tall kneeling hip hinge. We've got that PVC pipe along their spine. They're sitting their butt back towards their heels. They're working on maintaining a neutral spine positioning as they hip hinge, but we just eliminated a little gravity by going tall kneeling. We're doing things like a hip hinge to a wall, where we use a wall as a tactile cue for sitting the hips back. A lot of different ways to train this. If we're dealing with somebody that has a good hip hinge pattern, but their deadlift sucks or they have deadlift pain, what am I doing? I'm coaching their deadlift. I'm using progressive loading principles with their deadlift. We're working on things like isometrics with their deadlift to strengthen them in weak positions, or just load them without movement by doing that isometric. We're working on things like GHD back and hip extensions, like you see here in the top right picture. Single leg deadlifts, Romanian deadlifts, deadlifts off of blocks where we raise the bar off the ground a couple inches. We're working on teaching them to brace, whatever strategy we can there to improve that individual's deadlift pattern, or what we see in the bottom right there. So maybe somebody that doesn't know how to really engage their lats during the deadlift. We attach a heavy resistance band out in front of them to a bar. We have them go through a deadlift or hip hinge pattern where that band is trying to pull the bar away from their body, and they have to engage their lats to keep it closer. So that's kind of how I go about correcting the different faults based on this treatment algorithm. But really what I want to talk a little bit more about is how do I go about getting somebody to deadlifting? So let's just be honest here. Like, everybody that walks in the clinic, we are not starting them with deadlifts on day one. Maybe things are too irritable. Maybe they don't know how. Maybe they're fearful of deadlifts. Or maybe this is an individual that comes to you from a CrossFit gym. They actually injure their back during deadlifts. And so you don't want to start them back day one on deadlifts. You want to progress them towards that. How do we do that? There are a number of different exercises that I'll use in my progression back towards somebody deadlifting. And so we kind of have a top left down the bottom right progression here that we'll talk through. Top left, and somebody that's highly irritable, not tolerating a lot of loading, I might use something like a Chinese plank, where their upper back and feet are on boxes or benches or chairs, and the middle is elevated. And so we're doing an isometric contraction of the lumbar and hip extensors to maintain neutral spine positioning. We can progress that or do that in combination with something like a PVC hip hinge, where we're working on that deadlift movement, but we're not adding significant load to it. We're just working on improving the hip hinge positioning and technique. We could do something like a hip thrust, whether that's double leg, single leg, loaded, whatever, like we see in the top right there, where again, the low back is doing isometric contraction, but the majority of movement is coming from the hip joint itself. That's a great way to start to initiate some loading in the low back, but be a little bit more hip dominant in that loading. We can then go to the middle left, where we're doing different carrying variations, whether that's holding kettlebells or dumbbells down to the side, having barbells on the body. But we just start introducing some axial loading to the spine through something like a carry. Middle row, middle column picture there is some back extensions off of a glute ham developer, or it could be reverse hypers off the edge of a treatment table or off a actual reverse hyper machine without loading. But that's a great way to start working on actually adding in a little bit more loading specific to the low back. I love doing these with this population. And then where things really start to get fun is when we start doing exercises such as bent over rows. So that's the middle row, far right picture, where basically we have an individual hinge over, whether they're holding a barbell, kettlebell, dumbbell, bands, but they maintain that hinged position as they then row that resistance towards their belly button. And so they're doing an isometric contraction of their low back in that hinge position and challenging it by adding in that row position there. And I think that heavy loaded rows are highly underrated in the rehab world when it comes to low back pain, just as underrated as actual deadlifts are. We can then progress that up to getting more to actually deadlifting individuals, where we're doing things like the bottom left, we're doing a rack pull here. The bar is elevated off the ground a little bit. We're decreasing the range of motion. We progress to something, or instead use something like a kettlebell deadlift, where we're lifting a kettlebell instead of a barbell. It's a little bit easier to teach. And then we can ultimately, hopefully, progress to a barbell deadlift where we can load individuals a little bit more. So there's a lot of different exercises. And I think understanding how and when to implement those exercises is really important. So we're going to talk for a few minutes on programming of deadlifts. And then I'm going to go kind of quick through this. And then we can answer any questions y'all have. I think the really important thing here for us to always remember when we're prescribing any exercise to anybody is that the prescription of those exercises that we give has to be sufficient enough to create an adaptive training response. We can't just stick to low load, light resistance exercises for 3 sets of 10. That does not create an adaptive training response. And so let's kind of dive into the scientific principles of strength. This graph here is from the book, The Scientific Principles of Strength, which is a great book to check out. And let's talk through a couple of these variables. The first one being overload. Overload is really important for us in rehab, and it's kind of defined as when the stimulus we give is within the maximal threshold of the adaptive system. Essentially, we prescribe enough loading or volume or dosage that we disrupt homeostasis enough that the body recognizes that it must adapt to be ready for this stimulus the next time it shows up. Or a different way to look at that is it's of average greater than recent stimuli. We're pushing the body harder than it's been pushed lately. When we give somebody an overloading stimulus, we then get to this stimulus recovery adaptation principle, where let's say this line, this bottom right graph, bottom right graph here is the stimulus recovery adaptation curve. And this line represents an individual's fitness level. When we provide an overloading stimulus, we actually decrease fitness a little bit because we break down the muscle and tendon tissues, because we use up the chemical messengers and we use up muscle glycogen. Their fitness level actually goes down. Then what hopefully happens is they recover from that stimulus and positively adapt so that now they're a stronger, fitter individual. That's what we want to see when we give an overloading stimulus. The problem with that is, as we give an overloading stimulus, we're decreasing the body's fuel stores. We're creating nervous system fatigue. We're using up these chemical messengers, or we're breaking down the tissue structure itself, or we're just psychologically challenging an individual. We have to now understand this principle of fatigue management, of how do we compensate for this breakdown. And this is a really important one for us to understand. If we go back to this page here, where we have a bunch of regressions from a deadlift, we have to understand that something like a Chinese plank isn't near as taxing on the nervous system as 5 sets of 5 at 80% of an individual's 1 rep max on a barbell deadlift. And so somebody can maybe, from a fatigue management standpoint, handle Chinese planks every day, could handle PVC hip hinges every day, but couldn't handle barbell deadlifts, Romanian deadlifts, and rack pulls every day of the week. And fatigue management becomes very important here in us not providing too much of a stimulus to an individual. So often in the rehab world, we'll see, or it's not in the rehab world, in the strength and conditioning world, we'll see individuals programming as a percent of somebody's 1 rep max, where, for instance, traditionally, and this is not what we believe now with the research, if we want to program to improve hypertrophy of a muscle, traditionally we believe that we're going to program 1 to 3 sets of 8 to 12 reps at 70 to 80% of an individual's 1 rep max. Now we don't believe that so much. Traditionally, again, we believe that strength adaptation only happened at like 1 to 5 reps. Now we kind of understand that lifting both heavy and light loads can promote strength and hypertrophy if the training is carried out to fatigue or perform at the high level of effort, which to me is really cool stuff here. So if we go back to this graph here, there's another scientific principle of strength, and that is phase potentiation, which basically means that as we train one fitness variable, it can make us have better potential to improve other fitness variables. So for instance, if we do a hypertrophy block, if you make a muscle bigger, it now has the potential to be a stronger muscle. So to me, when I combine that principle with this stuff, it means, all right, let's say Sally right now is in a situation where she can't tolerate a heavy loaded barbell deadlift, even if we do it from a rack pull. And I have to stick with Chinese planks and carries and barbell thrusts. Well, I'm going to do those for a high volume, carried out to significant fatigue, so that maybe early on in her rehab, we're thinking about this as more of a hypertrophy block where we're trying to just make her muscles a little bit bigger. And then later on, through the principle of phase potentiation, as things get calmed down more and we start to move towards these heavier, more intense variations, such as barbell deadlifts, maybe now we have the potential to make those muscles actually stronger. And I think that's an important thing for us to understand there. A lot of times I simply program off of rating of perceived exertion. 0 to 10, how hard do you feel like you felt? I typically tell people, I want you to feel like you're working out at a 7 or 8 out of 10 intensity. And that's typically enough that we're challenging them enough to be pushed to do a little bit more. Quite often, and not as frequently in low back pain, but I'll give them this Silbernagle pain model on a scale of 0 to 10. How much pain do you have? If it's discomfort, 0 to 2, that's okay. If it's greater than a 5 out of 10, maybe that's too much. If it's between a 2 and a 5 out of 10, that's acceptable, but that's kind of monitor what happens over 24 hours and make sure 24 hours from now you're not increased. With low back pain, people's rating of pain, I think, gets off a little bit. So typically I just ask them, is that an acceptable level of pain for you or not? I hope all of that made sense and I could kind of wrap up this programming in a way that becomes a little bit clinically applicable to you. I'm going to give you 3 case studies here before we open it up for questions that I hope will tie all of this together a little bit more for you. So the first case example is a 30-year-old male that I actually treated, or all 3 of these I actually treated. He'd had 2 years of nonspecific low back pain. I did repeated motion testing with him, and that was negative, so he didn't have a direction of preference. He had a lot of neural tension, a lot of a positive prone instability test, and he was an incredibly hypermobile individual. He was positive in the Bite and hypermobility scale, but he actually expressed the desire to want to deadlift. And so for him, his rehab kind of looked like this. We did slump sliders to work on that neural tension. We did a lot of hip hinge work to work on him doing a better job of posteriorly translating his weight, because if we went back to his hip hinge test, he looked like this on the far right. He just flexed his trunk forward. So we worked on his ability to posterior weight shift. We worked on his bracing sequence. And then we did sumo deadlifts because he was pain-free with sumo deadlifts, but he did have pain with conventional deadlifts. And then our basic treatment goals here were we're going to decrease the neural tension. We were going to build strength through full range of motion and increase his lumbar spine strength and endurance. He did fantastic with that progression. A second study here kind of goes back to, it's not all about how heavily we load the tissues. Sometimes it's more important to think about how challenging we stress an individual psychologically. And this was a poor girl, 16 years old, she came to me with complaints of low back discomfort after sitting 1 hour in class. And she actually said it was low back discomfort. And unfortunately, she had at 16 years old, 2 previous MRIs showing herniated disc, and she was incredibly fearful of her low back. No abnormal findings or symptom reproduction with a really vigorous exam. I'm talking overpressure at in ranges of motion, multiple repetitions of repeated motions, segmental exam. Nothing really reproduced her symptoms. And so I really felt for her, with the fragile mindset she had here, that getting her where she was deadlifting significant weights would actually be something that would psychologically free her. So day 1, we started with kettlebell deadlifts. We worked up to 3 sets of 5 with a 25-pound kettlebell. And I asked her, on a scale of 0 to 10, rating of perceived exertion, How hard do you feel like that was? And she said it was a 2 out of 10. So in my mind, I'm like, yes, we can load this up a lot more. But then I stopped myself for a second and I basically asked her, would you feel comfortable lifting more? Do you feel like your body can handle more? And she said, not today. She said, I don't know how my body's going to respond after today. I think I'm okay, but I'm not sure if I could do more and still be okay. So for me, I felt like at this point, I had psychologically created an overloading stimulus on this individual. And that psychological overload was what I needed and was a positive effect from this day. And so basically, I then educated her on self progression as she feels comfortable, told her to go work on kettlebell deadlifts at the gym for the next 2 weeks till I follow up with her again. And this girl did absolutely amazing in her rehab. And it's one of those people that I regularly think back on, and I'm so happy with how well she did. Third case study here is a competitive power lifter. He competes doing a conventional deadlift, not a sumo deadlift, but he could not deadlift past 25% of his one rep max without pain, doing his conventional setup, but he could sumo deadlift really heavily. Now, he needs to practice his conventional deadlift because that's what he's ultimately going to do in competition. But he had positive slump tests, positive straight leg raise tests, especially when we added a little bit of adduction to him. It became even more positive. So for him, a lot of neural tension on board here. So we were doing a lot of neural gliding techniques. But his deadlift homework was that he did conventional deadlifts as part of his warm up, increasing until the point where he felt like, all right, if I push it anymore, I'm going to be creating negative side effects. And at that point, he switched to sumo. So he practiced the deadlift form that he needs to do for competition, and then he switches to the non painful variation so that he can continue to work towards pulling heavy weights off of the ground just for that psychological effect of pulling heavy loads. So he felt confident going into his upcoming meets because he was still touching heavy weights, but also still getting to practice the form of deadlift that he needed to do in his practice. So I hope those three case studies kind of tie together a lot of the different concepts that we've talked about tonight. We've got several more minutes here, so let's just kind of open it up to what questions do y'all have related to the utilization of deadlifts or any of the exercises that we talked about tonight in low back pain rehab. And you can mic up or type them in the chat bar because I have the chat bar open up now. I think barbell rows are underrated because in most rehab clinics I go and talk to, they do rowing variations, but they don't do it from that hip hinge position. And you can actually load up people with barbell rows significantly. So, I'm a 500-pound deadlifter and I can do barbell rows with 200-ish pounds. So it lets me really work lumbar spine endurance for a significant portion of time. Um, and you get that long isometric contraction in that positioning. There's some research showing that basically barbell rows do create some shear loading on the spine. And so I like them as a way to kind of bridge the gap between somebody that is very shear intolerant as things start to calm down, but maybe they're not ready for conventional deadlifts. Anyone else? Awesome. Well, thank you everybody for hanging out tonight. I hope you all have a wonderful Thanksgiving. As always, please feel free to reach out to myself or any of the ICE faculty if we can be of a resource to you. That is my email address right there. And I'm always happy to chat with you. So have a great night and a great Thanksgiving. Hey, Gmo, we need to catch up soon, buddy.